بسم الله الرحمن الرحيم. في البداية طبعا بشكر اللجنة المنظمة على رسائل الأستاذ ماهر فؤاد على دعوتي لأن شرف عظيم ليا أن أشارك في هذا الميتنج. واختيار برضه الموضوع اختيار يعني رغم أن قلت دكتور ماهر يعني من سنتين عملنا نفس البرزنتيشن ده فهو أصر إن البرزنتيشن يبقى موجود. So I'm starting my presentation by this photo. The presentation is intermingled between two photos. This is the first one, and another photo at the end. And you will be asked which photo is more beautiful. So I have the honor to have this photo with Professor Maher Fouad. When you search through our the SNT Virtual Academy, we have now more than 1,455 lectures. Only one presentation entitled Pharmacogenetics of Immunosuppression that I presented since 2 years in this conference. And today I'm going to update. So the focus of the talk, I start introductory by what are the current immunosuppressive medications. What about the concept of personalized medicine? Then what about cytochrome B polymorphism? So I'm going in a tour to show you the studies that show that the gene polymorphism can explain the variability of the drug levels and the ABCD polymorphism. So these are the major players that I addressed through my presentation, and I end with a conclusion and my last photo. So according to the United States data system, these are the current immunosuppressive drugs. The majority of patients are under induction therapy, and I am sure that Professor Arul Bak will highlight all aspects about the induction therapy. But as you see, the majority of patients currently are under induction protocols. Regarding cyclosporin and tacrolimus, this is the margination. So cyclosporin was the leading drug in the last of the 80s and the starting 90s. And from 96 to this moment, cyclosporin is vanishing on the start of immunosuppressive protocol in the United States. And tacrolimus is the leading drug. Why I'm stressing on this information? Because the majority of pharmacogenetic studies cover tacrolimus. Again, it is not only cyclosporin that was replaced by tacrolimus. Azathioprine was vanishing too in transplantation. Azathioprine is still present in the treatment of autoimmune diseases, but in transplantation, you see by the figure it is very clear that azathioprine is replaced by mycophenolate mofetil. And mTOR inhibitor is still not finding its place in the percentage as we thought. So the steroids, approximately currently 65% of the patients are treated with steroid in the initial phase and within 1 year of transplantation. And I think this is also our portfolio Mansoura. We start tacrolimus and we spare steroids for the moderate risk and high risk patients, and we use MMF. With refinement of immunosuppression, acute rejection, either diagnosed on a clinical background or biopsy is diminishing through the years. Again, the tacrolimus is the major player in immunosuppressive protocol nowadays. As you see in this article, look here at the variability of patients according to the tacrolimus level on the chart. Find this is مش عارف البوينتر فين ده. فين الليزر يعني. So if you look at this is the concentration, you find that the chart there is a profound variability among the patients, even from very low level to very high levels. So still, although it is a practical way to monitor tacrolimus is to measure its level, but there is a lot of variability. And this study showed if you have tacrolimus below than 8 nanogram per ml at discharge, this is reflected by two-fold rise of biopsy-proven acute rejection. So it is very crucial to good monitor our drugs, especially the tacrolimus. Regarding the concept of personalized medicine and the role of genetics, in the last decade, there is a major advancement in the technologies. So the technologies outpace the practical guidelines regarding the use of genetics. So we have specific single gene tests. We have genotype panels, selected susceptibility variants, next generation sequencing. All these are technologies that even give us a good idea, as Professor Torres mentioned. I can know the whole human genome. The direct-to-consumer, even direct-to-consumer services present as shown in this table. We have genotyping and so a lot of advancement in the technology of genomics studies were evolved last decade. And not only the genomics, but the omics. There is a difference between genomics and omics because one of the omics is transcriptomics, which is the gene expression profiling, the protein production proteomics, the metabolic products metabolomics. All these can lipid production, lipidomics, so a lot of advancements are there. But the most important is whenever we see this in the practical and in the practice. So regarding pharmacogenomics, it is the study of the role of inherited and acquired genetic variation in drug response. What the difference between pharmacogenomics and pharmacogenetics? Pharmacogenetics are studies that concentrate on individual candidate gene. So if we look at the relation of pharmacogenomics and pharmacogenetics with drug, this pharmacogenomics and genetics plays with pharmacokinetics, as Professor Torres mentioned, pharmacodynamics, idiosyncratic. So this is the interplay between the genes and the drugs. And I'm not going to explain all these issues. The drugs is metabolite. All drugs are metabolite through two phases, phase 1 and phase 2. And if you look to this, all these metaboliting pathways have genetic polymorphism. What's meant by gene polymorphism is that we can have different forms from the gene. So we have the gene, but we have multiple forms. This is what's meant by genetic polymorphism, a lot of alleles. If we look at one of the key players in the metabolism of immunosuppressive drug, special tacrolimus, is cytochrome B3A5. If we look to the races, although this study included the low number of the patients, if we look here to the black, we found the majority of the blacks are expressor. So 75% of the blacks are expressor. What's meant by expressor? They have this gene is active. Gene is active means that these patients need larger doses of the drug to attain the same level. If you compare to the Asian, 50% are expressor. If you look at the Caucasian, the majority of Caucasian are non-expressors. So if you apply one dosage regimen, like 0.1 milligram per kg per day of tacrolimus, you will find different concentration in different levels among all these persons. And this has proven in many studies. If you look at this model, if you look either tacrolimus milligram per day, twice daily dosage, or milligram per kg, you will find at any point, you will find if you compare persons who are non-expressors. Non-expressors are linked to 3. These are non-expressors. Whenever you have either 1, it is homozygous, or 1, 3, it is heterozygous for gene expression. So we collect 1, 3 and 3 and 1 as expressor, 3, 3 homozygous non-expressors. So if you compare at any moment in the drug dosage, you find that the level is lower in the expressor in comparison to non-expressor. What is the situation in pediatric? To show the proper transit, tacrolimus is affected by all these demographics, including the cytochrome system, which is the genetics. If you compare the level between non-expressor who carries 1 and non-expressor, you'll find at different time points that the expressors, to have the same level, you should increase the dose by approximately 1.84. And here, the renal transplantation, liver transplantation, and cardiac transplantation too. To the extent, this is a model to predict the dosage. So in children, the main determinant here in this model for the dosage is gene polymorphism. If the patient is non-expressor or expressor, the weight of the child and plus the hematocrit. In this diagram, in this model, they consider hematocrit of 33 as normal. Above 33 is normal. Below 33, hematocrit is low. Suppose that you have the patient in this hematocrit above 33, it is normal. His weight is 30 kilograms. So if the patient is non-expressor, you just need 0.1 milligram per kg of tacrolimus. If this is the same patient by all characteristics except he is expressor, you need 0.2 to have the same level. So almost a double dose to have the same level. Regarding liver transplantation, this is one of the big series, including 694 liver transplant. Cytochrome system is not present only in the intestine and in the liver, but also present in the intestine. So the combination of the characteristics of donor and recipient affect the level. Here, if you compare here, this is a combination of heterozygosity or homozygosity regarding expression in comparison to both the donor and recipients are non-expressive. Always there is a difference. And here they measure the adjusted dose. So they divide the concentration of tacrolimus by the dose in milligram per kg. So the higher the concentration divided by the dose, this means that the patient is in the non-expressive because he needs a lower dose. So here, if you compare the expressor, you find they have variability ranges from 1.9 folds and the same. So, and in cardiac transplantation, the same. If the open septum refer to the expressor, you find here the dosage is always lower to have the same level at different time interval after cardiac transplantation. And this was established in this table. Again, this is still I want to convince you that the genetic polymorphism are evolving. This is the effect of genetic polymorphism for two genes and the concomitant use of voriconazole on blood tacrolimus concentration in patients receiving hematopoietic stem transplantation. And this is just accepted, and this article addresses the issue of the using tacrolimus intravenous infusion and the issue of voriconazole. You will find here if the status of the gene polymorphism is non-expressing, this affects the level on day 14 and day 21. Another study, and this is a randomized, prospective randomized study, and this is one of the few studies that you find in this field as randomized studies. This included 62 expressor and 58 non-expressor. Both of them were known before transplantation, and they were further randomized to receive either diltiazem or not, and they found that the cytochrome, the presence of gene polymorphism affect the level, and if the patient is expressor, the role of diltiazem will be enhanced. Again, this is another issue, the genetic polymorphism and rejection. In this study, they addressed another gene, cytochrome BE2E1, and this gene is linked to the oxidative stress, and the presence of this gene increases the odds of acute rejection by type 1 sex. Another gene is linked to post-transplant diabetes, and this is by odds ratio 1.8. And another scenario, the pharmacogenetics can explain why the use of omeprazole plus tacrolimus leads to very toxic level by studying the complex genetic in these patients. Another study, this is the tacrolimus, and this is just accepted. Which genetic determinant should be considered for tacrolimus dose? This was the question of the study. The study addressed the many genes, and they found in this study only cytochrome B3, E5, and E4 gene polymorphism affect tacrolimus. Another key player in the genetic polymorphism and in genomics is ABCP, which is multi-drug resistant gene. This was the old name, or P-glycoprotein, and the protein encoded by the gene is ATP-dependent drug efflux pump. And to show you the efflux pump, this cartoon explains this issue. If the patient is CC genotype, this means that the pumps are very active, so only few of the drug is absorbed. So this is the effect of CC genotyping regarding HCP. And this is if the genotype is CT, the pump is made well, so the modest drug is absorbed. And if the pump is not active, And in TT genotype, a lot of drug is absorbed. And this may explain why different persons have different level for the same dosage of tacrolimus. This system, ABCB genetic related drug bounce, is not only present in the intestine, but also present everywhere. So here, for the lymphocyte to be suppressed by the calcineurin inhibitors and to interleukin-2 to be decreased, we should have these drugs inside the lymphocytes. So the bombs are present in lymphocytes, and there is discordance between CD8. This is the ABCD in the donor and recipient. If the both donor recipients are TT, the addition needs a lower dose. This is what I mean in CD8 and CD4. Here, if the patient in the genotype TT needs a lower dose to achieve reduction of interleukin-2. Regarding the cyclosporin, this study showed that if there is certain genotype carry the risk for cytomegalovirus, and this very large study included more than 4,400 patients, and they studied 5 genes, more than 50 genotypes. And if you look here, the presence of CC genotype in Birmingham cohort affects the survival of the patients. In Belfast is the same. So this is a correlation between genetic polymorphism and survival. Again, in tacrolimus, there is effect in survival. Regarding preemptive pharmacogenetics, one of the most important systems is to have the enhanced computed system. Here, this is a pre-test. The computer will show this alert for this patient to use adacerebrin. It's better to have this gene assessed, solubulin methyltransferase, and this is the warning after the test. This is a post-test. If the patient has the polymorphism, that means that the drug will not be metabolized, the patient will suffer from toxicity, tumor toxicity, and this is a cartoon shows that this is poorly metabolized in patients. The lowest possible dose of the drug should be used to have the drug be used safely. Again, if you want to review this topic, you can refer to this recent review, Pharmacogenetics and immunosuppressive drugs, showing the same. If you have genetic polymorphism for the azacerebrin, you will find severe myelotoxicity. For phenolic mofetil, other genes that may induce rejection. For cyclosporin, tacrolimus, sirolimus, a lot of genes. But I want to emphasize that sirolimus and everolimus are not, in all the studies published, are not, there is a big debate if there is any rule for cytokines for the genetic polymorphism assessment. The major limitation and challenge for pharmacogenetics include the study design that were published are not well-randomized control studies. To convince us to change from drug monitoring to the pharmacogenetics. If we know the pharmacogenetics before transplantation, we can personalize medicine, but up to this moment, there are no convincing studies for that issue. And there is what's known phenotypic, genotypic heterogeneity. If you find the gene, but there is no phenotypic, this is very problematic. And the ethical concern, but nowadays for the patients, they are assured because there is a new Genetic Information Non-Discrimination Act of 2008 in the United States, lack of cost-effectiveness analysis, and limited availability and lack of education. Up to this moment, we should depend upon therapeutic drug monitoring. The use of pharmacogenetics is only used in studies or at below 10% of centers use pharmacogenetic, but it seems that the trend is moving toward, this is the last slide and last photo. Why I got this, this is a photo of Angelina Jolie. This one of the Hollywood stars, and this take a very correct decision in 2013 to do prophylactic mastectomy. Bilateral prophylactic mastectomy. Why? Because she has a mother died of breast cancer, and she carries the breast cancer gene. So when the doctor discussed with this with her that if she did the bilateral mastectomy, she will be saved from mortality from breast cancer from 80 or more than 85%. She was convinced and was subjected to prophylactic bilateral mastectomy. And if we have the same in transplantation, that if we apply pharmacogenetic, this will be Related to solid outcome, I think we should have pharmacogenetics to be added to the monitoring of our drugs. And thank you very much for your attention.